everyone is here and get started. I'll take roll while you guys are reading something in a little bit. So you all know me. I don't have to introduce myself, but I know that you guys actually may be more experts on this topic than I am, because you all are taking some of you are at LSU and you're taking Team Up as part of your curriculum. And so I just wanted to, though, because interprofessional education is a requirement of AHEC scholars, I wanted to make sure that we were prepped and operating as a team to do case studies, because I've gotten a great opportunity for us to work with scholars in South Carolina and do a few simulations with them using our expertise and their expertise, sort of trying that. And so that's coming up, and I just want to make sure we have some language for that headed into that experience. And so I sent you guys a little booklet from Team Steps earlier this week, and I hope you took the time to review it, because the stuff going through it can be kind of dry. And so I'm going to really try to get us through the informational part so we can get to the meatier cases, and then it'll be a little bit more enjoyable of the session. So I just want to pause and see if anybody has like general questions or anything that we need addressed before we just jump right in. Okay, gotta give an extra second, an extra beat for Zoom. All right, so what we're going to be talking, this is called case simulation, but really what my hope is that we, like I said, we can develop some shared language around how to operate teams well. And so I'm using the Team Steps curriculum, which is has 5 key principles. If you please. Oh, good. Okay. Oh, wait, I'm sorry. Let's do our learning objectives. So my hope for today is that we'll collaborate with an interprofessional team to develop a comprehensive team-focused patient care plan that will identify and use available community resources to aid with patient care. Because I think a lot of times when we do these simulations, unlike in real life, we kind of think about sort of the clear-cut parameters of what's on the page. But I would love it if we could kind of expand that and maybe pretend like these are real cases, and maybe think about what the real referrals we might make would be. And then also demonstrate understanding of each discipline's role in patient care and the benefits of utilizing an interprofessional team approach to improve patient outcomes. Right. So Team Steps has its, actually has its background in, I think, the Naval, in the Navy. And it's an evidence-based framework to optimize team performance, but now we use it in the healthcare delivery system. And the acronym stands for Team Strategies and Tools to Enhance Performance and Patient Safety. Like I was saying, Team Steps is comprised of 5 components. There are 4 teachable skills, and then the concept of team structure that sort of surrounds those 4 teachable skills, because those skills are no good if you don't have a team to support the skill sets. We have, I'm sorry, there's a lot of commotion right now in the room I'm in. There are of those 5 skills, there's communication, leadership, situation monitoring, and mutual support. So we'll start with communication. So the key communication skills for Team Steps include, and we're going to go through these: SBAR, call out, check back, hand off, and pass the baton. And really what we're hoping to develop is a structured process by which information is clearly and accurately exchanged among team members. Like, you know, lack of communication kills in our line of work. The 2 big skills here are exchanging information and accepting information from others. It's not just one way, there's actually an exchange. And in healthcare, you know, really it's not only between the people who are on the care team, but it's also between the care team and the patient. And so it's important to engage your patient or your client as much as you can. So we'll start with SBAR. Situation, that's an acronym. So situation, background, assessment, and recommendation. And so it's one technique of many that can be used to standardize communication. And it's really helpful in care settings because then you can be sure that the same kinds of information are included every time you go to communicate. And that consistency can be really good because then the listener knows what to receive or what they might receive when you communicate with them and vice versa. The other thing we have in our back pocket is call out. Which informs all team members at once during emergency situations. And of course, it helps us anticipate next steps. An example would be airway status. And then someone says, airway clear, breath sounds decreased on right. And everyone, you're saying that so that everyone can hear that information and use it in the activity that they're trying to carry out in the coordinated team. And also, it's really important that the leader, whoever they are, and I hope and pray that we'll all be leaders at one point or another, will reinforce the responsibility of the team members by asking them for a call out. So it's a way of asking someone if they're following through on an activity without being like, what the F are you doing over there? So you just ask them, airway status, Check back is kind of the inverse. And so it's another closed loop communication strategy, just like call out, to ensure that information conveyed to the sender is understood by the receiver as intended. And so there's a repetition. In other words, the message is sent, the message is received and repeated back, and then that information is confirmed. So for example, doctor says, give me 25 milligram Benadryl IV push. The nurse says, 25 milligrams Benadryl IV push. And nurse says, that's correct. Doctor says, that's correct. I feel fancy just saying this out loud. I'm not a clinician, so this is a nice opportunity to sound like one. I'm just going to get through all these communication skills and then pause and ask if there are any questions. So like I said, I'm zooming to get through the boring stuff and get to the good stuff. But if you guys have any kind of hesitations here, do stop me and let me know. So we got SBAR, call out, check back, and now we have handoff. And there's another, this is like word and letter salad. So there's another tool for you to use for handoff that can help you make sure that you are inclusive of all the information you may need to convey in a handoff. And that's on page 13 of your pocket guide. I really don't want to go through it. But if you have any questions about that, please let me know. Basically, it's just a bunch of key pieces of information, including you introducing yourself to begin with, PASS, the patient, the assessment, the situation, safety concerns, so on and so forth. If I say it to you, you're going to forget. So the big thing is, though, on handoffs, regardless of what acronym you want to use, that you understand that when you're handing off a project or handing off, this is true not only in clinical settings, this is true in life. I mean, I've definitely gotten this feedback when I was a young person in public health. Not that I'm not still young, but when I first started working, which is that I wasn't necessarily passing off all the information I needed to pass off for the next person to quickly pick up the baton and get running, if you think of it like a relay race. And so this is especially critical in patient care. And we're about to do our first scenario, and you'll see. So it's important that you realize that, especially in patient care, while that patient's in your care, they are in your care until you hand them off to another qualified carer or someone who can be responsible for them. And so, there's responsibility there, there's accountability that it's your accountability as the hander-offer that you're sure that both parties are aware of the transfer of responsibility, because someone may not know that you're giving them something to do, And then finally, there's also the question of uncertainty, that you make sure that there's none, that you clarify everything. And and then also the acknowledgement that the other person has received the information. Finally, a big thing about handoffs is that they're a really good time to review and have a new pair of eyes to evaluate both the situation for both safety and quality. And so if you have a patient that you have concerns about, you've been watching them all day, you can tell the person who's coming on that you've had concerns all day, so that if an emergent situation occurs, that person has the information that, oh, there's a history of some symptoms or whatever, you know. So we're gonna do our first scenario. I'm gonna give you guys a second to read through it. And then you guys tell me what you think about it. You may even wanna grab a piece of paper. You don't have to do this, but you may wanna grab a piece of paper just to make some of your thinking notes, because we will do some talking here. So I'll just give you a second. Okay, so who wants to start? And I guess I'll be clear, what I'm looking for is maybe using some of the tools that we've covered just now. What was missed? What were some opportunities to prevent the injury of the patient?
I think looking at the scenario, one thing that maybe could have been done is, I mean, we don't have all the information, but just telling the patient not to try and get up from their wheelchair, because I don't know if anybody necessarily told them, like, hey, just sit here and we'll be right back. Don't move from the wheelchair.
Yeah, we don't know. We don't have any information about that patient's mental state and whether or not he has the ability to comprehend that instruction, right? Mm-hmm. And so without that, that's one option. What are some other options?
Could you also pass the baton here?
Yeah, that's good. Yeah. So one thing that should have happened was that if there's no caregiver available to accept the handoff, then the attending caregiver really has to remain with the patient. It's not an option to walk away. So that's one big one. The other one is definitely the handoff. And so one of the things that someone may not have known is maybe that there was a safety issue at all, right? So, oh, I'm sorry, go ahead.
Maybe they didn't communicate well. Maybe someone wanted to do the handoff correctly, but they didn't use the two-step strategies just to repeat what's the next step, or just to communicate well with the next person responsible.
Yeah, right. Yeah, thank you for saying that, Masa. The next thing I was going to say was exactly that, which is that the receiving nurse has to accept the responsibility of the patient before the other nurse can walk away. So, okay, great.
And I want to comment that I feel like in a lot of the discussion that TeamSTEP had about teamwork, it included the patient. And so I feel like part of the situation could be avoided if the patient was considered a partner in the care and could have said, like, you know, don't leave me in front of a counter, or, you know, could have helped with ideas to prevent something like this happening.
Definitely. I think especially in a situation where he has a history of being unstable and confused, it's probably best that he not be left alone by whoever he's in the care of. And whoever is caring may or may not, it's unclear if that carer had the information to know if, you know, if we can really track this back. So
Is
What
the
would be-
implication that we know that he gets confused and he's unstable, or are we just like you would never leave a patient alone?
I think that I'm not a clinician, and so I am not trained as a clinician. Someone else should jump in. But I think that if it's known that leaving a patient who has a history of being unstable and confused alone could put them in danger, then you can't leave them.
Okay, sorry, I just missed that one word.
Yeah. Understandable. I miss one word all the time. Okay. So, Nora, I wanted to ask you, like, in ideal world, how would you see this unfolding done differently in a way that engages the patient?
I mean, I guess it depends, because if they're currently unstable, then you might need to have like a very clear plan of action. I was in church at one point, and there was a person who like pretty regularly would pass out in his wheelchair, and he had a sign that was like like around his neck that said like, this is a normal thing
Don't
for
wake me up.
Don't wake me up. So I feel like if there's some foresight, then you can use like signage and
Yeah.
messaging ahead of time.
Yeah, I think that's a really good idea. And I think that if you are in a setting where you care for a lot of patients that often find themselves disoriented, then that's something that your team can definitely communicate around and engage the patients on. Like, what are the ways that make you feel the most comfortable for us to communicate about you when you're under, So, because I don't know, I mean, I don't know if everyone's gonna like the sign around the neck idea, but I definitely point taken. Okay.
I mean, there are people that have falls often that would wear like helmets and pads too, depending on your condition.
Yeah, for sure. It's not unheard of. All right. I'm glad that that I'm kind of bummed I put so many scenarios in, because I see how well we're going to talk. So I might skip one or two. And I just want to highlight here the power of nonverbal communication. Y'all remember when it like resting bitch face was a thing that we were talking about a lot. We can say a lot of things by how we move our bodies, and that includes making patients aware of your level of comfort or discomfort with them, and you can make their care experience. You can change their care experience by communicating with them non-verbally even. And so I think it's really important for us to also highlight that while the verbal communication is also really critical, there's a lot of nonverbal communication that happens that really affects the care experience and other things. So any thoughts on that? Okay. All right, I'm gonna skip this next slide. All right, so our next skill that we're gonna talk about is leadership. And our key skills and tools for leadership include effective team leadership. And really the big one here is ensuring the regularity of team events. And those are briefs, huddles, and debriefs. Great team leaders have the ability to maximize the activities of their team members by ensuring that all the team actions are really well understood, that changes in information are shared, and team members have the necessary resources. And so it's really, really, really critical that we always highlight the word resources, because resource can take a lot of forms. That can be intellectual resource, that can be monetary resource, that can be a lot of different stuff. But your leader is really responsible for making sure that all of the cogs are oiled, that everyone can really do their job well. And there are a few key characteristics of effective leaders, the ones Team Steps highlight. I mean, there's so much research on leadership, so I don't want this to be like your definitive treatment of leadership. But among the characteristics of effective leaders are role modeling and shaping teamwork through an open sharing of information. 2, providing constructive and timely feedback. And 3, facilitating briefs, huddles and debriefs, and resolving conflicts. So the really big thing with the briefs, huddles, and debriefs is that if you can imagine the brief as a planning session where you sort of get briefed on the situation, or you get briefed on what your day will be. And then you can have huddles iteratively throughout the day to problem solve. And at the end of the day, you come back together and you say, what worked, what didn't work, what do we do better next time? Great leaders, not only do they do this, but they do it with regularity. And they're really the person on the team that makes sure that those briefs, huddles, and debriefs happen. So let's take a look at this scenario. All right, so does anybody have any thoughts on what should happen next? And maybe even if you really want to thrill me, how it loops back to leadership?
So I understand that the son was called away, but he could have at least told a nurse or gone into the examination room and told his dad or something, you know,
Yeah,
Mac, that, hey, I have to go. I'll call somebody. But since that didn't happen, maybe um, in our day and age, trying to see if Jack has another family member or a friend. And if not, then maybe like calling him an Uber or a Lyft.
good job. So in this scenario, and there are infinite ways that could have landed, right? And I'd love to know if anybody else had other thoughts, but Tassim.
Yeah, well, I mean, I was just to add to that, I feel with addition to the son's responsibilities, I think the health professional that the Jack was seeing, like before he got out of his appointment, should have maybe inquired, oh, do you have, because obviously he knows the conditions of the patient, or they know the condition of the patient, and they could have inquired, like, do you have a ride home, or how do you, like, how are you going home and stuff. So maybe that would have been nicer. But
Yeah. Well, in this scenario, the nurse made quick work of taking leadership of the situation and taking the lead on the situation. She called a quick huddle with the nurse and the billing specialist, and they arranged for a taxi, or now an Uber. And they also called to make sure that he made it home, which is part of this handoff thing, right? Making sure that you're aware of where your patient is at. All right, mutual support. So another teachable skill in the Team Steps framework, in addition to communication and leadership, is this idea of mutual support. And there are many tools in mutual support. There's task assistance, feedback, advocacy and assertion, the 2-challenge rule, CUS, and DESC script. I'm not sure if they call it desk script or what, but the idea here is that it's really the essence of teamwork. And it's kind of where the rubber meets the road of the discomfort of teamwork too, isn't it? Because it's feedback, it's advocacy, it's all the kinds of things that can make us bristle a little bit. But it really provides you with the ability to anticipate and support team members' needs through accurate knowledge about their responsibilities in their workload. So with respect to task assistance, it should be actively offered and given whenever there is concern for patient safety or concern related to workload. So how could task assistance reduce error?
I think it's just a matter of if you have somebody that's overworked and they're trying to multitask and do too many things at one time, they're just bound to make a mistake. So if there's somebody, and also a lot of times, a lot of us have a personality that we don't want to ask for help. So if you have somebody that's actively making sure that you're getting assistance to avoid that overloading, then you're more likely to actually take advantage of the assistance that you have, because even if there is somebody that's there to help you prevent it, if it's kind of like a we'll help you when you need help, then you're not going to ask for it. So having somebody that's there and it's like, what can I do to help you? Then it helps you to avoid doing too many things. So then it helps you prevent making mistakes because you're trying to do things too quickly or too many things at one time.
That's right. You got it.
I think it can, on the flip side of that, it can also get rid of the, like, that's not my job mentality, and kind of take on this, like, oh, it's not just this person's role, it's all of our roles to ensure, I mean, in this case, patient safety or whatever it is.
Yeah, definitely. I love that this is a good framework for the healthcare world, but I don't want to, like I said, I don't want to limit it to the healthcare world, because I definitely could have benefited from this training myself entering the working world, So I think the big key things is that mutual support undermines the ability of people who like to do everything themselves to do everything themselves, whether or not it's a right thing. I'm speaking for myself. And it also really does center the team on the safety of the patient, right? Or on the success of the project, which is really good. And then when it comes to feedback, like leadership, there's so much research and feedback. And I think that what I really just want to say about it is that there's a little tool in the booklet as well, but I'll just say that good feedback is timely, respectful, directed, and considerate. And my best advice to you is to always ask somebody before you get started working together how they prefer to receive or deliver feedback, because a lot of times you can get a much better reception if you know that your one bud down in audiology likes to be emailed, but your other friend likes to talk face to face, so it's very helpful to have that sort of already worked out beforehand. Now for advocacy and assertion, that's talking about patient advocacy or advocating for the spirit of the team, right? It's invoked when team members' viewpoints don't coincide with the decision maker. And so there is another set of steps that they recommend that you take for advocacy and assertion. Assertion, not the I word, assertion. Make an opening, state your concern, state the problem, offer a solution, and reach an agreement. And I think, we're going to get to some advocacy scenarios and where I think we can really hit this point home. But I think that the big thing for advocacy is that as long as it is that the critical point there is that it be like I said, centered on success, centered on the key goal, which is quality care, successful care, or, if you're working on a different kind of project, the success of that. So now we'll talk about, if there are no questions about that, we'll go ahead and move on to the 2-challenge rule or those last 3 ones. Okay, so within this section, there are actually 2 conflict resolution options. One is the script and one is the 2-challenge rule. And the way you pick between the 2 is whether or not the problem is with information or the problem is interpersonal. If it's informational, then you use the 2-challenge rule, which is that you make an assertion. If it's ignored, then it's your responsibility to voice your assertion at least 2 times. So at least 1 more time and to ensure that it has been heard. This can be really helpful in your private life too. I think we've all seen movies or had one of those moments in life where, you lived with some misery for forever, and then you talk to your friend years later and they're like, I had no idea you were upset. And you're like, I tried to tell you, you maybe didn't. And so it's really important that you always try twice. And the 2 challenge rule is the foundation of that. And so if the root of the problem seems to be informational. So doc calls in a script that, let's say, looks like it might be the wrong dosage. The pharmacist calls and says, doc, is this the dosage that you wanted to call in? So it's kind of a callback. And he says, yes. And then pharmacist, she says, well, doc, I think that I've never seen a dosage this high of this drug for this size person. Are you sure? And doc goes, you know what? I was thinking of the wrong medicine. So that 2 challenge rule is really about that informational piece. If it's an interpersonal conflict, then we kind of go into the script piece, which is that you describe the specific situation, express your concerns, suggest alternatives, and state the consequences that you view as being the outcome if the trajectory isn't corrected. Does that make sense? Okay. All right. They had a really funny little, like, only cuss, in the right situations sort of thing that went along with that, but I hated it, so I took it out. But the idea is that cuss, which is, let's see, I'm pulling up my little reference, 30. It is an acronym for the 3 biggest reasons to stop the line. So there are assertive statements that you can sort of holler out, and if everyone is trained in team steps, they understand that those are everyone stop, focus moments. So it's kind of a way to wave the flag and say, there's an issue here. So I am concerned, I am uncomfortable, or this is a safety issue. I like the last penguin the most, the timeout penguin. All right, so here's a scenario. Arden, do you feel like they're talking about you here? Are you Smith?
Oh yeah, I'm definitely that person that's like, no, I can do it. And it's like, I'm trying to learn to be better about it for sure.
It's a practice. Does anybody have any thoughts about this?
I think it's smart because I've definitely been in like technician 2 situation.
Yeah, me too. And you've been like, I've got something else I got to do in like 10 minutes. I also think that technician 1 is really smooth, right? Because she doesn't make Smith feel at all like they are inadequate or like there's something wrong with them. She's just like, I'm got some free hands, let me jump in.
I like how specific technician 1 is too, because if somebody just comes up to you and says, oh, I can help you if you need help, you're kind of like, oh, I don't have, but if they're very like, I have this much time, let me help you do this thing, then it's much easier to say, yes, you can help me do this thing than if somebody just says, let me help you, and you have to take the time to like explain to them what you need help with and where that kind of thing. So
you're on fire with this section. Yes. That's
so in
Go ahead,
my
Mark.
experience, there's like a few different kind of waves of comfort in a job where like at a certain point I would feel like very smooth, like technician 1 about, what needs to be done and how to say it to a person. But there absolutely are times in a job where like you're awkward and you can't anticipate or make assumptions about what your colleagues would want you to help with. So I could see this backfiring if you're like making assumptions that aren't right.
Yeah, I think that the key part of this is that it's in a tech role, and so there are just sort of like steps, and they have the same job, and so I think that really helps the scenario, because I totally understand what you're saying, Nora, and I've been there myself as well, and I also hear what Arden is saying, that like, if you give me a blank check, I don't even know what to tell. If I'm that swamped, like I have no idea what to tell you, what the first thing is that I really do. You know what I mean? And so, yeah, I guess we can't all expect to be as smooth as Technician 1. We'll just have to try.
I think part of that also comes from we're quick to want to do something, but taking a step back and like analyzing the situation to see what's going on, you know, before you offer your assistance, to actually look at what's happening and see what's going on and see how you can help.
Yeah. I think that's really key. I also think that that there's an important piece here, which is that Technician 2 is comfortable delegating, or Smith is comfortable delegating. She goes, okay, thanks. There's this thing here to do. So it kind of takes out the what if factor that Smith would have been like, go find your own x-rays, man, you know? So they are scenarios. All we can do is talk through them. But I think that you really hit the nail on the head, Arden, with this idea of the situational awareness combined with the mutual support. It's a real teamwork skill. And so this is obviously an idealized scenario, but I think that there is something to lift from there. Are we good? Okay. All right, situation monitoring. So we have 3 skills for situation monitoring. We have STEP, cross monitoring, and the I'm safe checklist. Situation monitoring is the process of actively scanning and assessing situational elements to gain information or understanding, or to maintain awareness to support team functioning. This enables team members to identify the potential issues or minor deviations. So some benefits can include that it fosters mutual mutual respect and team accountability, provides safety net for team and patient, which is really big because it means that we are watching each other's backs. So some examples of situation monitoring include assessing the patient's condition, noting malfunctioning equipment, and being aware of workload spikes and stress levels among team members. Lastly, remember that you should engage the patient whenever possible. So coming back around to this idea, like Nora was reinforcing earlier, that that the patient is a collaborator in their care. And so when we're talking about all of these sort of team things, then we need to make sure that if the patient can communicate, that they're being communicated with. So let's see, starting with STEP. And like I sort of alluded to, it's this cross monitoring. It's this watching each other's backs piece. So the components are the status of the patient, the team members, the environment, and the progress towards the goal. And so with respect to the status of the patient, we ask, what's the patient's status? Their vital signs, their medications, their stress level, that kind of thing. With team members, how are they doing? What's their fatigue level? Are they stressed? Are they skilled? And then for the environment, are the exam rooms properly stocked? Are the blood pressure cuffs, the otoscopes, the ophthalmoscope, the eye thing, are they working properly? Do we need any special equipment for a procedure today? Are there enough staff to attend all the patients? and the progress towards the goal. Ask what is the progress towards today's goal. Like, you know, are we behind? Are the patients waiting too long? Are things being left undone because there's time pressure? Is the plan still appropriate, or does it need to be revised? Those kinds of things. So we have another scenario for my dental divas. So what didn't they do? What's the first and most basic step that they didn't do?
Check for their name
Yes.
is what I would say.
You nailed it, Haley. You're a great dentist. So, yeah, I mean, they didn't confirm that the patient they were working on, the chart that they were working on, was the patient in the chair. What else did they not do? Or do?
Put away one of the dental records.
Thank you. Haley's nailing it. This is good. So even if one team member did the right thing, it would have been fine. Now, in this case, hopefully nobody got cut open, but like, you know, we can imagine if it's the left arm instead of the right arm or something like that. Okay, good. Any other thoughts on?
Well, I just remember from a personal experience when I was a dental assistant in undergrad, the dentist would always say, okay, what tooth are we working on today? So it would be on the schedule, and then he would double check with the x-ray in front of him, and we would make sure we were looking at the right side of the x-ray, and then he would double check right before he started drilling just to make sure it's always the right tooth too.
Yeah, that's perfect. Yeah. So that's really important because that's also, so not only is that situational awareness, but also that's taking in some of those communication skills like check back, right? Where you say it back and then somebody responds, is show me the tooth, and then you look at the record and cross check it and okay, this is the right mouth. Perfect. Yes. All right. All right, now the next one is the I'm safe checklist. And really this is just, I have a friend who has one, the acronym is really funny and it's escaping me right now, but it's basically the same thing. Am I, you know, but in her case, it's what she uses when she feels like implacably bad. And so she said, am I sick? Did I take my meds? Am I stressed? This is the healthcare version of that. So are you sick? Did I take my medication, or is my medication in hampering me in any way? Am I stressed? Am I still drunk because I drank too much last night? What's my fatigue level? Did I eat? Did I pee? Did I poop? I feel like it's a pretty comprehensive list. Anybody have any thoughts? And really the point here is that if you feel good, you do good work. If you don't feel good, your odds of making a mistake are much higher. So encircling all of this is this idea of, so we have these 4 components, and then we have the team structure that makes the 4 components come alive, right? The team structure are the people that use those teachable skills. And that team structure that is also working towards patient safety. And there are so many people that go into this. I mean, we are not in the scope of this talking about ancillary staff like janitorial folks and all those guys, but I mean, everyone has a role that sets foot in a care setting. And so we'll just do this next scenario. I think this is how I would describe most mornings at my house. Who has thoughts?
This seems like my worst nightmare. But
Do what?
I'm sorry, what did you say?
Who didn't do what?
Oh God, I think the whole team kind of didn't work together in this situation.
Yeah. So like, if this were your clinic, Haley just acquired this clinic, and one of your staff dentists, this happened to them on the first day of you having this clinic, what would you do?
Well, I mean, it seemed like it happened so fast that the patient was already transported, but hopefully it wouldn't get to that level. I feel like we would have adequate emergency training before this type of stuff would happen, so that each person had a role and everyone knew where emergency materials were, like a spare set of batteries for blood pressure machine, or I mean, everybody in the office that I used to work with had a specific knowledge about something. So one of the assistants knew where the oxygen tank was. The other one knew where the, gosh, I don't know, just emergency
Sure.
medicines were. And then every month they had a job, like the first Monday of each month, to check the expiration dates on stuff. And just everyone had a job and we all knew what to do.
And in this situation, did folks know other people's jobs too, so that someone could fill in if the other person wasn't there?
Oh yeah, we had plenty of assistants, like at least 2 people knew where each thing was. And then in this situation, it seems like an hour is a very long time to let this go on. Like for an hour, rapid blood loss is happening. That's a long time.
Yeah, I mean, I wouldn't know, but I do. Reading this one makes my palms sweat. This one's a tough one.
Yeah.
Does anybody else have any big standouts on this one?
So I was thinking like this, it seems like there's just a bunch of too small and like tasks that are too small to justify a like daily brief. But I think if like we huddled after this kind of situation, it might make sense to go back to like really basic briefs in the morning where it's like, okay, you know, did you who are responsible for this do this thing? And maybe you just have to do that for a while until there was like an environment that would prevent this kind of a situation from happening again.
I agree. I think that's good.
Yeah. Oh, sorry. Go ahead. Go ahead.
Thank you. This is like what we talked about handoff. The last person who used the machine should have told somebody about like if there is any problem or the machine has like any issues. It's part of communication skills and also like how we talked about handoff.
Yeah. Yeah. Yeah, I agree. Okay. All right. We did it. We got to the scenarios that I was hoping to get to. And so if you check the chat box, there is a PDF download. And let's see. Oh, wait, no, it's, see, I was in a different, I had already launched, I don't know why it didn't work, but I had already launched the Zoom meeting and I was sitting there like by myself and I'd already loaded all this stuff. So just give me a second so I can send it to you guys. Did it do it? No, it didn't. Oh boy. All right, let's try this again. Sorry, guys. Let's call it an intermission. The other thing is that there are so many doggone windows open when a Zoom is happening. That's really disorienting. Let's see, meetings. There we go. It did it. I feel really good about that. All right. I'll give you a second to read it.
Is anybody else having to sign into Dropbox?
Yeah, I am.
Yeah.
Oh, I'm sorry. Okay. Is it better if I just email it to you guys? Or thing is that it can't really, it'll be so small if I try to put it on the screen. You know what I mean?
I would appreciate an email because I don't have Dropbox.
Yeah, let me do something different. Do you guys have easy access to your Google Classroom right now?
Yeah.
I will put it on there. I wish this bar weren't at the top of the screen. I am putting it on, oops, on the thing for this one. Okay. If you go, I think I can just give you the link. I'll put that in the chat. Maybe that'll make it easier. Since I'm here already. So let me know when you'll have it, so that way I can stop feeling anxious.
I have it.
Okay, good. Thank you for putting me out of my misery. Okay. I'm going to assume that people have made some progress in reading it. I'm looking for nods.
Yes.
Okay. All right. So this is actually, I have to admit, kind of a tough transition for me because I historically have done case review professionally, but for prevention purposes. And in this situation, you guys are a little bit more skilled than me because you're going to look at this differently in a more longitudinal fashion rather than the other way. And so, given the context of this case, she's presenting at an emergency room. So she'll see physicians first. But what I really want is for us to think about not just the ER, but also how we can coordinate the care for this individual in a dreamland. So I really would love my public health professionals talking about resources. Like I really want the folks on the phone who think about community health and emotional behavioral health stuff to participate in this as well. So I'm just going to go ahead and open the floor. Does anybody have some initial thoughts?
Well, just from reading the scenario, one of my initial thoughts was just that how come there was nobody following up on her after she had been prescribed oxycodone? So I kind of feel like as healthcare providers, they dropped the ball on that one because nobody was following up to make sure that she was not developing a dependency on it, because this is obviously she did in that time.
Yeah. So I'm just going to take some notes as we talk. So there's the question of prevention, right? So we're talking about prevention. So the follow-up to prevent dependency. So, but what we have came in for, oh, Nora.
So also I think hepatitis C, when it is congenital, is really dangerous. There aren't treatments for treating hepatitis C in children. And so you'll get like liver cancers in teenagers if a child gets hepatitis C from their mother. So that there needs to be a lot of education and kind of birth control with folks that are living with hep C or at risk for it.
So I guess let's back up. So I think I'm taking notes. I think those are both great points. I just want to put us on a rhythm here. So we have 29-year-old Caucasian female. She presents at the ER because she's withdrawing, and she really wants to quit. She's pregnant, and she wants to quit. She's pregnant, has not had any prenatal care because because of her dependency. And one of the things that really jumps out to me is that she's had this high-risk pregnancy. So I'm scanning this thing. So there's, for Nora, she's pointing towards, okay, well, when this baby is born, we're going to need intensive follow-up because the baby has, is it potentially a danger? I'm thinking she's had a high-risk pregnancy already. So the best way to get a high-risk pregnancy is to have already had a high-risk pregnancy. So this pregnancy is already high risk before we have the complicating issues, right? And so we need to figure out how to stabilize her, how to get this baby out of her safe, and then how to coordinate her care going forward so that she can safely stay clean because that's her desire. So let's talk. What do we got? Do we just let her off gas on her own in an ER, or do we put her on medication-assisted treatment?
Be on medication-assisted treatment, or else there's risk of, what's it called? miscarriage. Yeah.
Yeah. So we need meditation assisted treatment. Do all obstetricians know how to treat a patient that needs medication assisted treatment?
No.
So we need somebody. Who do we need? We need an addiction psychologist on the care team, right?
That was definitely about to be my, not the addiction psychologist, but psychologist in general. I mean, she needs a psych eval to start with.
Yeah. That's definitely true. Okay. So we need someone, so we're thinking about this care team. We're going to need a neonatologist because of the Hep C. We know that, and the high risk pregnancy. We know that for 100% sure. We're going to need someone who specializes in behavioral health to collaborate with her OB, right? Because that OB is not going to necessarily be an MAT specialist. What else do we need? What are some non-clinical services, like maybe some services we might find in the social services fields?
Something that I was thinking is that this is like, because she already has Hep C, but from what I remember, I think Hep C is transmitted via blood and bodily fluids, correct? So if she has it, her child has probably been exposed to it, the one that's already born, 3 years old, and then her husband probably has it because they've been sexually active. So with addition to the multitude of things that she needs help with, like in addition to healthcare, it seems like, I think having a proper healthcare access would have prevented all of those. In regards to at least she would have been kept up on, and her family's health would have been kept up on, maybe preventative in regards to the Hep C at least, where she would have been checked up on and whatnot, and given the proper advice and education.
Let's loop back around to prevention soon. I know that that's our public health instinct, but let's try to get to the care team first.
Okay.
I got your note though. I got you, Tassine.
A social worker would be good to have.
Good. So maybe like a home visitor, somebody who specializes in maternal and child health home visiting, right?
So I feel for her fear of having involvement. So I know that they're like, depending on where you are, like you kind of know which organization it is that does a good job of like providing people with support and reducing the chances of yeah. So like, not just any social worker, but the right social worker.
Right. Someone who is equipped to handle complex cases like this one, right? Is anyone else? So I've got a neonatologist, a behavioral health specialist, an obstetrician, a social worker, or a home visitor. That's appropriate, as appropriate. She's going to need a healthcare home to go to later, right? After she delivers.
I think I was going to say, I think something that was like jumping out for me reading this was that her family's not aware of her substance use. And so I feel like she's probably feeling pretty like isolated right now. So in addition to just sort of like behavioral health, like going to counseling, I think maybe trying to find like resources for peer support, something like maybe some sort of group, just like a variety of options, like give her options of other things that are out there.
Mm-hmm. Yeah, so like, Kelsey, I'd love to hear more about maybe like what kinds of groups that are like that. So that were on your mind that you thought sort of like rang the bell for you.
Well, I mean, there's always like NA type groups, but I don't know. I not everybody likes that sort of stuff, but some maybe something along those lines. I don't know, or if there's any like community clinics that might just have like support groups that might not necessarily be led by a clinician. Yeah.
I think one of the things that really belies her need for some behavioral health support is that she says that there's no history of substance use disorder, but her dad hit the bottle every day, right? So she has memories of her father drinking. So it seems like she's not really in tune with, it seems like maybe like some of those connections could be made with some peer support, or like Shikara was saying with like a psychologist or a psychiatrist. I mean, psychiatrists don't really do therapy, but
yeah, or like a psychoeducation group.
Right. Yeah. Okay. And so,
hey, this is Brooke.
Brooke.
I know I'm not playing the game, but what about like the WIC clinic for nutritional support for her other child?
Yes.
The baby?
Does anybody need someone to say what a WIC clinic is?
Yes, please.
Brooke, do you want me to do it, or do you want to do it?
Well, the WIC clinic is women, infant, and children. Isn't there an extra C in there?
No, it's always made.
One C?
Yeah, it's just like, that's your population.
I feel like there's an extra C in there. So it's for these women and children from the, underserved communities that are below the income levels and are in poverty, and they need nutritional support, and it provides them with the basics like eggs, milk, cheese, and it also gives them nutritional support while they're there and education. And eating this, healthy babies, healthy mom, those kind of things. And then once the baby's born, they provide formula for the baby to make sure the baby is getting the nutrients they need, so we can still have healthy mom, healthy baby.
That's really important too. I mean, I'm not a formula lover. By virtue of being a maternal and child health professional and having no children, I have lots of opinions about formula. But
they do breastfeeding education also, and if you do choose to breastfeed, they will give them other different kinds of foods that are better for breastfeeding mothers.
Right. So breast is best. And if you are someone who is using or is on some other kind of medication that is passed through breast milk, then formula is best, and it's really expensive. And so it can be a tremendous support to have some financial assistance with that through WIC. Anything else jump out?
You had kind of already started saying it, and also going off what Tassim said, but they definitely need some kind of primary care physician, like both for her for after the baby is born, but also for both for the children. I'm thinking like a family medicine, somebody that could kind of see them all, instead of definitely like some kind of pediatrician maybe for the children, but somebody that can see them all. And then also like her partner, if he's been regularly having intercourse with her and she has hepatitis, then he might have it too. So somebody that can can offer them both some treatment options. So some kind of PCP, definitely.
Yeah, for sure. Are we going till 7:15 or 7:30?
7:30.
Okay. So I think I'm counting 1, 2, 3, 4, 5, 6, 7, 8 different people, like touch points, I should say. 8 different touch points we just brainstormed off the top of our head that this woman could really benefit from, right? So, excuse me.
Before we move on, can I just comment that, so there's this film called The Providers on PBS that follows this one doctor. I can't remember her name, maybe Dr. Hayes or something like that. And she won like a national award because she is a family physician. So a family physician can do pediatric and adults And she has training in buprenorphine. So in this video, it shows this doctor, you know, treating a mother who has a 3-year-old who's pregnant and who uses opioids. And so I just keep thinking about her, where like, if you provide educational options to, you know, doctors, then like maybe you don't have to have as many people on the team.
Definitely. I think in her case, regardless of whether or not she is adequately managed with medication-assisted treatment, she has a history of trauma and substance use disorder in her family. And so she probably would benefit if she were interested in it from that psychiatric piece, I would think, and social support piece. But I think that there's a point. I think you're making a good point, Nora, because I mean, how could everyone do? I mean, that is, if we weren't moving on, that is exactly where I was headed. I was going to say, how do you get all these people in one room? Like, how do we do this? You know, you were right on target. I mean, it's not uncommon for neonatologists and OBs to work together, and for those people to refer out to WIC clinics and to home visiting services. But a healthcare home is just still sort of a thing that we talk about in meetings like this. It's not like there aren't like necessarily these buildings called healthcare homes laying around, you know? There's who makes these calls to do the handoff? The physician? I mean, you're doing all the paperwork. Like, how does this get done? What do you guys think?
I just want to throw out there real quick. This is more for the child. Just maybe like later on and after, you know, she has the baby. Hepatitis C is a risk factor for hearing loss. So just making sure that you have a good pediatrician and audiologist for that child, just to make sure that there's no, you know, development of hearing loss. And then that'll open up something totally different for the child.
Yeah, so I'm going to throw out one that no one thought about and probably wouldn't because they didn't work as a state MCH coordinator for 5 years, but we also have a program for early intervention called Early Steps, and that's nationwide. And if you think you might do some work in this kind of world, then you should get familiar with WIC and with Early Steps and those big sort of HRSA grants like that, because they operate nationwide. And Early Steps is important because if a baby is born under stressful circumstances, or there's some suspicion that the child may develop a delay, then it's either born with delay or may develop delay. Then they are assigned a caseworker, and the caseworker comes in and does like physical therapy with the baby and like some other kinds of like neurocognitive things. And that is an incredible resource to make sure that kids that might fall behind don't fall behind and can start pre-K when it's time. And of course, the school system can be its own public health intervention sometimes. So I'm going to put down Early Steps.
This is Brooke again. I'm just going to throw a plug in there. I worked for Head Start for a few years.
Yeah.
And the Early Step kids feed into Head Start. And without that early intervention, some of these kids that I had at 3 and 4 would have never made it in kindergarten like they were supposed to. So it's a very valuable resource. Volunteer with them, something. Look into Early Steps. That was just my plug right there.
No, I appreciate it. It's perfect. I think Early Steps is a really important program.
I have one more thing to add. So
yeah.
I was listening to the webinar you told us about in an email a couple days ago about HPV and anal cancer, and something that they stressed is offering the patient resources of like a national organization or foundation or something like that offers them a lot of education, then I feel like a lot of people don't actually, you get diagnosed with something, you don't look up like the foundation for it, and that could be a really good resource too. And it's not necessarily a person
Yeah.
to get them in contact with, but it's a good resource to let them know about. And I don't know if something like that exists for heroin, but I imagine it does.
Well, so that's where I actually was hoping to sort of tie in that disability video, that ableist disability video that I sent you along with the pre-work. And I'm wondering, because I think it's important that people remember that it's not just the visible disabilities that cause problems. There are also the invisible ones, right? There's substance use disorder, there's bipolar disorder, there's all these things. And so with thinking about her as someone who has a degree of disability based on her substance use disorder at this point, because she's sick and withdrawing, she's going to need a lot of support. And so I come back to this question of like, I mean, it's an impossible question to answer, but I really want you guys to be thinking about this. Like, if you have a patient, this patient, if you're going to be an OB one day, if you're going to be a primary care physician one day, this patient is going to walk through your door, and you're going to know that easy, you could come up with like 10 different organizations for her to interface with, and that would make sense for her to interface with. And it's a Herculean charge to have this kind of stuff coordinated. And so this case was really important to me because I just saw so many different angles in it. And I really felt like, man, this is such a comparatively good outcome because she's still alive, Does anybody have any final thoughts on, oh, thank you, Tessine. Thank you. Tessine put a link for that that movie in the chat, and I am definitely probably going to watch it tonight. Thank you.
There's also, I'm going to put a link for like a short 2-minute that's just with that one doctor I described.
Cool. Thank you so much.
I sort of had a last minute thought.
Yeah.
I guess I was just thinking throughout this, thinking of like all these different people to refer her to just be thinking about what, if she has insurance, what kind of insurance she has, just generally like what's her socioeconomic status, like any financial resources, what transportation looks like for her.
All that stuff matters.
Yeah.
It does. When we do case fatality review and you do an abstraction from medical record, you have a lot of that information and it's set up a little bit. This is set up the most closely to an actual like case review to any of them, which is why I lifted it with permission from South Carolina. But we have only 4 minutes left, and that's only probably enough time to read. So you have this second scenario. I'm going to offer it to you as a reflection assignment. If you want to get an hour's worth of didactic, feel free to take that second scenario and do a reflection with it. How about that? I'm assuming y'all would rather do that than stay late.
Sounds good.
Yeah, sounds good.
Figured. Okay, good. All right, well, y'all will be getting the evaluation through Google Classroom shortly. I will put the slides and I'll trim the video and put it up soon as well. And I just want to go, I'm going to read down oh, Valentina, say it out loud.
Oh, I didn't want to interrupt you. And it wouldn't be someone, like I wouldn't refer her to an audiologist right away, but as she recovers, I think it'd be a good idea to refer her to one because chronic heroin use can cause hearing loss. And well, we know that affects quality of life. So.
Thank you. And alternative, if if anybody wants to write a reflection on the prevention aspect of that first case, then feel free. Instead of going forward, if you want to go backward and think about how it could have been prevented, then you're welcome to do that too. And so all of this stuff will be up on the site for you in the coming days. I am going to try to read over some of your lit reviews in the next few days. I would love it if we could set up a check-in individually or team-based with each of you or each of your paper teams so that we can just make sure that everyone is still feeling good. And so if you could email me individually with a time that works for you, please do, so that we could just set aside 30 minutes to an hour just to chat like we did last time. I just want to make sure that everyone's doing okay. And finally, I'm going to read the attendance that I took today. And if I didn't call your name, scream. I have Tassin, Masa, Nora, Valentina Rabin, Jansen, Arden, Haley, Katie, Kelsey, Shakara, and Valentina Carrillo. Okay, great. All right, you're all free. Have a great night. See you later.
Bye, guys.
Thank you. Bye.
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 Thank you, Robin.
Thank you. See y'all later.